Sure. So Get Counted Get Counted is a community initiative that really began in response to some identified needs for more accessible information about NM and greater access to patient tissue. So we knew we already had the infrastructure in place to answer these needs, but the community seemed to lack an awareness of these resources and didn't understand the purpose or the benefit to supporting them. So we began thinking about this and developed a plan that we thought would do a really good job of addressing this need. And we met with leadership from across different muscle disease groups to collaborate as well. In doing this, we were able to develop what ended up being 4 objectives in this initiative that we've collectively called Get Counted. And it encompasses these 4 well-defined objectives, which are to get connected, get registered, get consented, and get donated. We have been working with a team of volunteers from the NM community, but also other muscle disorder communities. And we've been putting in place the necessary components to promote awareness of this, such as the logos that I'm sure a lot of you have seen on Facebook and in emails. We also have flyers and videos. So the first objective we saw as just kind of a way to ease into the idea of a campaign like this. Get Connected encourages people just to connect with each other. And because Facebook, we saw as the primary way that people are choosing to connect in the NM community from all over the world, it just made sense to promote doing more of this via Facebook. And then the second objective, Get Registered or Counted, encourages people to register with the CMDIR, which is the International Registry.
Go ahead, Stacy.
Okay, so the second objective, we see this as really being a good way to organize our community's clinical information, which will allow us to estimate the treatable population and also attract valuable attention from scientists and potential investors in developing treatments. But we can also use this information to better inform clinicians, scientists, and our very community about NM. Of course, it will be useful, we think, for natural history studies, biomarker studies, that sort of thing. And then the third objective is Get Consented, and that encourages people to consent for tissue donation with the CMDTR, which is the tissue repository. We know that tissue is needed to test theories and treatment drugs, and we have established the system to centralize the process, making it simple for patients, for families, and for the scientists. And then the last objective is Get Donated, which is to encourage people just to remember the tissue repository for donation opportunities, such as when they're planning a medical procedure, just to contact me and find out if it might be an opportunity to donate some spare tissue. Really, the easiest way we've found to build the repository has actually been by transferring leftover muscle biopsy tissue from other medical centers, and we've been really successful at that.
I'd like to give you some information about respiratory management so that you understand that and can put it into perspective. And then you can continue with your conference. I have 5 questions here that Mr. Katz gave me that many people and relatives of patients with Nemelin myopathy often come up with, often have these questions. And the physicians themselves don't understand these very well. So if it's okay with you guys, I'd like to give you some information that you can put into perspective with your other objectives. Is that all right?
Sure, thank you.
Now I'm going to tell you some things, and I'm going to try to respond to these 5 questions that Mr. Katz gave me, and then you can ask other questions. What it comes down to is that many of my patients with all kinds of neuromuscular disorders, when they have very severe progressive conditions, they can weaken to the point that they become continuously respirator supported without ever being hospitalized or getting any invasive tubes. When this is done properly, you can put people on nighttime ventilation that prevents symptoms of underventilation, and if the condition is very progressive, they can need ventilatory assistance during the day also, and that assistance can be done often by simply grabbing a mouthpiece every minute or two, or using something called a exsufflation belt, something that goes on the belly that moves the diaphragm to ventilate the lungs. And when patients get sick with colds, they use a cough assist to prevent pneumonias and stay out of the hospital. However, when they do get pneumonias and they need to be intubated, and 10 doctors are telling them they need to be trached because they don't know how to extubate them otherwise, we have a close to 100% success rate at extubating people who are continuously ventilator dependent with conditions like Nemelin myopathy. So, on the other hand, when patients get tracheostomy tubes, 4 out of 5 eventually die because of the trach tubes. So, tracheostomy tubes are rarely, if ever, needed in Nemelin myopathy, including for people who need 24-hour ventilator assistance. Now, with that being said, one of the main reasons why people do go into acute respiratory failure is because of oxygen therapy. Oxygen has absolutely no place in the treatment of Nemelin myopathy in the home. Now, if somebody is intubated with pneumonia and your ventilation is being controlled, there's no problem receiving oxygen. But the oxygen must be discontinued and the oxygen saturation must be normal before the doctors extubate, take the translaryngeal tube out of the throat of anybody who has pneumonia or who was in respiratory failure. So oxygen will only turn off breathing and cause the breathing to stop. In other words, there are more respiratory arrests triggered by oxygen therapy than by anything else for people with neuromuscular disease. The second point I have here is failing to use the cough assist or at high enough pressures. This is very true. In the 1950s, the cough assist, or what was called the coughlator, was used at 40 millimeters of mercury pressure by everybody. Now, I made the mistake in 1993 of saying that the cough assist was the equivalent of the coughlator, and it should be used at 40. But the 40 in the cough assist is centimeters of mercury, not millimeters of mercury, centimeters of water, not millimeters of mercury. So I made the mistake of considering the two machines equivalent when the new machine was calibrated in centimeters of water. 40 millimeters of mercury is 54.1 centimeters of water. The cough assist is useless at under 35 centimeters of water, and almost nobody should be using it at under 50 centimeters of water. In fact, it should be used at 60 centimeters of water for most patients, and almost always at 70, which is the maximum of the machine, when it's used through tubes like translaryngeal tubes or tracheostomy tubes. The next point that's down here is incorrect ventilator settings. The PEEP is too high. Yes. What sleep doctors do is they treat sleep disordered breathing by giving CPAP or BiPAP to patients. Now, I will explain this in simple terms so that people understand this. When people get old and they snore, they often have obstructions in their throat that prevents air from effectively getting into the lungs. The treatment for that is continuous airway pressure, so-called CPAP, which is a pneumatic splint. It's a splint made from air that keeps the throat open so that you can use your inspiratory muscles to ventilate the lungs. That's fine if you have inspiratory muscles to ventilate the lungs. And if the problem is that the inspiratory muscles are weak, however, the treatment is not CPAP or BiPAP. The reason that doctors don't understand this is because the polysomnograms that are always ordered on people with neuromuscular disease are programmed to interpret every problem, every what they call hypopnea or apnea, as occurring because the brain is not telling the muscles what to do. That's a central apnea, or an obstructive apnea because the throat is obstructing. The polysonogram was never programmed to interpret the problem as being from muscle weakness. That is, the diaphragm is basically too weak to ventilate the lungs. Because the polysonogram was never designed to do this, and the sleep doctors don't even think about muscles, they prescribe CPAP or BiPAP for everybody. And how did this start? Well, back in 1990, very, very obese people who were maybe 400 pounds and had severe obstructive apneas, they not only have obstructive apneas, but their diaphragms cannot move all of the fat to ventilate the lungs. So what they did was increase the CPAP values to 15 centimeters of water, which is the maximum of the units. 15 centimeters of water is basically the maximum amount of CPAP you could give anybody, and it's like breathing with your head out of the window of your car going about 120 miles an hour. It's unbelievably uncomfortable. It's like breathing in a hurricane, literally. So the Respironics company sort of invented BiPAP, which allowed you to adjust the inspiratory pressure separately from the pressure you get when you exhale. Now, the pressure you get when you exhale is not only useless, it's counterproductive for people with weak muscles. But the doctors don't understand this, and neither does the polysomnogram. So BiPAP is still being prescribed for patients with Nemelin myopathy. The EPAP subtracts from the IPAP in terms of helping someone get a deeper breath. So we stopped using BiPAP many, many years ago. The inspiratory pressure is fine, but the expiratory pressure isn't. So when, if any of us get hit by trucks, and if I become a C1 quadriplegic and I have zero ability to breathe, what I would say is zero vital capacity, I can move 0 milliliters of air into my lungs. To ventilate me at about 12 breaths a minute, which is a normal rate, you have to give me a volume of about 600 milliliters, and the way to do that is by giving me an inspiratory pressure of about 18 centimeters of water. Now, if my lungs become stiff, or if I get very fat, you need more than 18 centimeters of water pressure. But that's the amount of pressure that's needed to rest your inspiratory muscles overnight so that weak muscles can be stronger during the day. If you stop my exhaling by giving me 5 centimeters of water of EPAP, then you've got to increase my IPAP by 5 to counter that. Now, I hope you understand that. The EPAP is not only useless, it's counterproductive and uncomfortable. And ideally, nobody with Nemelin myopathy should be using nasal ventilation with BiPAP. You can use a Trilogy or an LTV ventilator, but you should be using it on pressure cycling or volume cycling, where an inspiratory pressure is set or an inspiratory volume is set, but nothing stops you from exhaling into the atmosphere. The next question I have down here is to make decisions about trachs at the worst time. In my opinion, this is decisions that should be made when the patient is otherwise healthy. Yeah, that's true. The only problem is nobody with Nemelin myopathy ever needs a trach tube if they're managed correctly. And it says here, I want to learn that some people with Nemelin have chosen to get trachs as adults. They prefer the trach over non-invasive ventilation. Of course, personal preference is fine. What happens is that the patients are influenced by the biases of the doctors. And anybody who agrees to a trach as an adult has only done so because the doctor doesn't know how to use non-invasive ventilation and has no idea of how to use a cough assist to prevent people from getting pneumonia and respiratory failure when they're sick. And the same doctors also think that if the patients get intubated, they can't be extubated without a trach tube. So they tell patients they need to get trach tubes. Even children with infantile Nemelin myopathy should never need tracheostomy tubes because they can always, essentially always, if not always in fact, be managed without them. But it requires doctors in keeping people out of them and keeping them healthy without using invasive tubes. That's an unfortunate reality, and I'm writing a book about this now because it's an absolute disgrace. The last question I have here is relying too much on suctioning as compared to the cough assist. And that's true. If the cough assist is used properly, there's really no need for deep lung suctioning. In fact, it's impossible, virtually impossible, to suction the left main stem bronchus, which is why more than 80% of pneumonias in people with neuromuscular conditions occur in the left lungs because it's not possible to suction the right lung. For anatomical reasons, the catheter always goes into the right airways. Now, the cough assist essentially is non-invasive suctioning. It creates 10 liters a second of flow that can bring secretions out of the airways, and it's not going to preferentially clear the left as opposed to the right, or the right as opposed to the left, because it's just a flow of air. It's not a catheter that you're sticking down anatomical airways. So those are the 5 points that Mr. Katz gave me to address, and I'm happy to take any additional questions that people may have. If there was something that I said that you didn't understand, then please let me know, and I'll try to elucidate it a little bit further.
Dr. Bach, this is Amy. I saw you with my daughter Franny a couple months ago. Thanks for joining the call. I 2 quick questions. One, just for the benefit of the rest of the group, you showed me something with the cough assist that I had not learned initially from our other pulmonologists about syncing the cough assist with the child's breath, and I just wondered if you could explain that to the group a little bit. And my other question is whether you have a feeling about the use of percussion vests and inhaled steroids with Nemelin myopathy.
Okay, the cough assist, well, I hate to always refer to other diagnoses, but I have to because we have more data on certain conditions that are more severe than Nemelin myopathy. For example, there's a condition that you probably have heard of or are familiar with called spinal muscular atrophy type 1 or Wernicke-Hoffmann's disease. The reason I mention this is because in the severe type, the children are continuously respirator dependent before 5 months of age, and they never speak or swallow any food from before 5 months of age, and so they are more severe than almost anybody ever is with Nemelin myopathy. Now, I know there are exceptions, and children with Nemelin myopathy can be almost as severe as that. But it's rare for anyone with Nemelin myopathy to be continuously respirator dependent before 6 months of age. So, and to never be able to have spoken or eaten at all, okay? So, now, looking at that population, before these children are 2.5 years old, they cannot cognitively cooperate with the cough assist. So what we have always done is recommend that the cough assist be used timed to the children's breathing as opposed to using a timed mode that tries to overcome their breathing. Because unless the child is so weak they cannot close their throats to counter what the cough assist is trying to do, which is really rare, they're not going to benefit from the cough assist unless you make it in sync with the child's breathing. So, in other words, when any child's abdomen goes out, it protrudes, that's because he's inhaling, because the diaphragm's going down and they're inhaling. When the belly goes in, they're exhaling. If you time the cough assist to that, then you will help the child expulse airway secretions. So when the belly goes out, we give the positive pressure. When the belly goes in, we give the negative pressure. And we always give at least 50 centimeters of water pressure. That 50 centimeters of water pressure is not the pressure in the child's lungs. It's the pressure in the machine on the gauge. These children breathe so rapidly that you cannot generate 50 centimeters of water pressure in their lungs. So, and pulmonologists are always terrified about using pressures of over 10 centimeters of water because they're afraid of something they call barotrauma, which is appropriate in people with severe lung disease. It simply doesn't happen for people with normal lungs but who have weak muscles. So now, when you time it to the child's breathing, what proof do we have that it works? Unfortunately, we don't have any. Because for SMA type 1, the average number of hospitalizations and intubations are 1.7 per year until the children are 3 years old. After that, however, it's 0.3 per year until they're 5, and after the age of 5, it's less than 1 every 10 years. So in other words, as the children become able to cooperate with the cough assist, they almost never get hospitalized again. They may become 24-hour ventilator users using nasal ventilation. and more than half of them do before the age of 10. But they never get hospitalized again. And we have kids now that are supposed to have been dead before 6 months of age who are over 20 years old now. If that can be done for SMA type 1, it certainly can be done for Nemelin myopathy. Clearly, if these Wernicke-Hoffman's kids never need trach tubes, nobody with Nemelin myopathy should. But doctors don't know that. They just simply have, they don't know it, period. And if I show them these patients, they say, oh, they must have SMA type 2. Yeah, 24-hour event dependent before 5 months of age with SMA type 2. That's ridiculous. But this is the myths that neurologists make up to try to compensate for the dissonant information that, to inform them that they simply have no experience or knowledge of the subject. Anyway, that's what happens. The second part of your question was, sorry, could you tell me that second part again?
Sure. Use of percussion vests and inhaled steroids.
Oh, yeah, the percussion vest, okay, you have to understand a little bit about anatomy. The trachea, what we call, or the windpipe, divides 27 times. The first 6 divisions, you have to cough material out. The next 21 divisions, the cough doesn't work at all. It's dependent on the mucociliary elevators. Now, anything that vibrates the airway can work at the peripheral 21 divisions. So in other words, if your mucociliary elevator, if the little hairs that bring material out of the lungs are not working, then, like in cystic fibrosis, for example, then something like a therapy vest can shake up the material and move it up to where it can be coughed out. The vest cannot substitute for an ineffective cough, and people with Nemelin myopathy do not have airways diseases like cystic fibrosis. They have weak muscles and the cough is ineffective. So the therapy vest is not a substitute for an effective cough. Now, can it help at all? When somebody is sick and they have a lot of secretions in the peripheral airways, the therapy vest can probably be helpful, but it cannot substitute for an effective cough. And the primary problem in Nemelin myopathy is the cough. It's not the airways. So this is what you have to understand. Okay, any other questions?
Dr. Bach?
Yeah.
This is Cindy Canine. I just had a question regarding what you were just talking about. So you would suggest, my daughter Ellery is 6 years old, and we use the vest and the cough assist daily, for preventative reasons. So are you saying if she's not sick, you would suggest perhaps not using the therapy vest?
Yeah, you're really wasting your time. Unless she has continuous saliva aspiration and is choking on secretions pretty much all day. Even in that case, I doubt that it will do you any good. One time when I was lecturing for families of SMA, I told the mothers that after the child was sick, the pulmonologists usually tell them, well, continue doing chest physical therapy. And they do it 3 times a day all year round. And I told them to stop doing it. They were wasting their time. The next year when I went back, many of the mothers came to me and said, you don't know how many hundreds of hours you've saved me. The fact of the matter is, if the oxygen saturation is 95% or more in room air without giving oxygen, the child doesn't need anything. The child really doesn't need anything unless they specifically ask to get help coughing something out. So the therapy vest, as a preventive thing, the therapy vest is completely useless unless you have airways diseases, which children with Nemelin myopathy do not have.
Because she's been complaining of headaches, actually, after the vest. And then just regarding the pressures for the cough assist. Yeah. Because you explained, higher pressures. Like right now, she's on an inspiratory. I don't know if I'm saying this right, but for inspiratory, it's 35, and exhaling, it's 40. So you would suggest higher pressures. Yes,
and what you should do is increase it to 40 and 40, and then 45, and then 50 and 50, as long as she's comfortable with the higher pressures. But I can tell you that it's really 54 or 55 that has been demonstrated to be effective. Anything less than that is good. In fact, I've been doing a study for the company, the Respironics people, and we look at the flows that are created on the new cough assist. See, the new cough assist, the T70, has the ability to measure the flows as a function of the pressures you're using. And the flows are always better at 50 and 50 than they are at 40 and 40. And they're generally better at 60 and 60 than they are at 50 and 50. So if you want it to be effective, you've got to use it at the effective pressures. And the effective pressures are always at least 50 and 50. Now, if the person is not used to pressures of over 40, that's okay. Increase it gradually. Get it up to 45. And, most kids will be comfortable at 50 and 50 right away, but not everybody. So increase it gradually. 35 is absolute minimum. And if you're using it at low pressures like 35, you also need to press on the belly during the negative pressure to increase the flow. When you use it at effective pressures like 50 and 50, we find that there's no longer any need to press on the belly to increase the flow, which is something I never knew before. I always recommended that during the negative pressure, you should press on the belly in and up like a Heimlich maneuver to further increase the cough flows. And when you use it at low pressures, that is true. But when you use it at effective pressures, it's no longer necessary, usually, to press on the belly to further increase the flows.
So I wouldn't hurt my daughter. It would just depend on her being comfortable, whether she's comfortable at higher pressures.
Yes.
And can I mention that she is trached? And I think, like most parents...
Wait a minute, your daughter is trached?
She is trached.
Well, then you shouldn't even use it at less than 70. Because the trach tubes on little children are so small that the pressure drop-off is enormous, and practically nothing gets into the lung.
So it's not working the way it should.
No, at 30 is nothing, absolutely nothing. You've got to use it at about 70 through the tube, and use it on the inspiratory cycle until the chest is fully expanded, and then you go to minus 70 until it's fully empty.
Okay. Yeah. What's
Otherwise,
the pause
it's not
time?
going to do anything.
What's like the pause time?
But the pause time is irrelevant. You got to do it manually. You see, how old is Ellery?
She's 6.
Oh, so she's old enough to cooperate.
Absolutely.
Yeah. So once you have a child that's old enough to cooperate, you can set a pause time. You could set an inspiratory time and expiratory time. But on the babies, you can't do that because they breathe so rapidly. You've got to time it to their breathing. If you have an older child like that, you can certainly do that. But it's whatever she's comfortable with. See, what people have to understand is that there's 2 reasons that you use the cough assist. One is for coughing, which is the positive and negative pressure. Right. And through a trach tube, you really probably have to press on the belly also to increase the flows because of the tremendous pressure drop-off across the tube. But the other thing is just the positive pressure at least 3 times a day to expand the lungs. Right. Otherwise, the lungs don't grow properly. You have to expand them to their predicted inspiratory capacity. And the only way you could do that through the trach tube is by using the cough assist at pressures that will fill the lungs with air, at least 50 or 60 centimeters of water. You need to do that at least 3 times a day and maybe 10 to 15 times each so that the lungs grow more normally. Now, tell me something. Does Ellery eat or no? She cannot eat anything.
No, she doesn't eat. She just does tastes and sips water.
How old was she when she got the trach tube?
She was 3.
3?
And that, that's always like my next question is you always think, did she need it?
No, she didn't need it. I'll tell you right now she didn't need it. But can it be removed?
Well, that was my next question.
Yeah, before kids are 12, I don't like to remove trach tubes because they're very frightened and they don't understand well. But let me ask you this. Usually when patients get trach tubes, it's because the doctors never put them on nasal ventilation beforehand, or they get pneumonia and go into respiratory failure, and they tell the parents, well, they're going to have to get a trach tube anyway, so you probably should put it in. Now, once the trach tube goes in, almost invariably, the patient becomes 24-hour dependent on the vent and is not weanable. Is that what happened with Ellery?
Hold on one second. I'll be right there, honey. So, basically she was hospitalized for respiratory failure, and I guess she had pneumonia. She was in the hospital for like 2 months, and they did extubate her, and then she couldn't, maintain her saturation.
Extubation, right.
She
and
was
I'll tell you why
on
she
BiPAP,
failed. But was she using BiPAP before she was hospitalized?
She was.
Okay.
She was.
Okay. And I bet you the settings were 10 and 4.
I don't remember. It was so
I'm
long
sure,
ago.
I'm sure. See, the problem
and we
is,
always had issues. It was always hard. There was always leaks. There was always, something.
Yeah. Yeah, but see, she could have been extubated without a trach. And, but you would have had to have known to get her transferred to us. There's really no other way.
Right.
Now, there are sometimes the intensivists really do try to follow what we do, and they are willing to learn. But it's a small minority. They're very, very busy people, and they don't really want to make the effort to learn something new for a patient population that's very rare for them. And I can understand it, but
I just felt like that was the problem. Like when I was listening to Gavi's story, it just felt like it got to the point with Ellery that the secretions were so uncontrollable that she just was so weakened after the 2 months of the hospitalization. Like I could not see her getting over the hump.
But the secretions are caused by the invasive tubes. Now, before she got hospitalized and before she got sick, did she have a lot of problems with secretions?
No. I mean, she never drooled or anything like that. She had one other hospitalization prior to that.
But her saturation was normal. It was 95 or more in the air, right?
It was, except at night, of course.
Once you get a trach, the average trach patient who's an adult has to be suctioned 8 times a day because the trach causes airway secretions and it's colonized with pathogenic bacteria.
Right.
When the trachs come out, the secretions go back to exactly the way they were before the patients got trach.
Right.
So,
I mean, she needed suctioning, but probably just as much as she does now. It just seems like what these kids, when they hit a certain age, they just tip over. Like, everybody gets sick, everybody gets hospitalized, and they come down to that decision in the hospital. They're at that point where they need the trach, don't they need the trach?
I'm telling you, it's not necessary. Our kids with zero vital capacity for many years who have been 24-hour vent users since they were infants and are now over 15, they really don't have a problem aspirating secretions. And I think the reason is because they sit up in their wheelchairs at more than 90 degrees, and the secretions don't go into the airways. Now, they may drool, but the secretions don't go into the airways. So really, positioning is very important. And
so
I'm not sure what else I can tell you about that. I can just tell you that even for people with no throat muscles at all, zero movement of the eyes, the mouth, they cannot make even the slightest grimace, nothing. They don't aspirate secretions, and they're over 20 years old, even though 24-hour vent users since they were 4 months old. So clearly, nobody with Nemelin should need a trach tube. Now, is it easy? No, I'm not saying that it's easy to avoid. But the problem is that you need doctors who understand this as outpatients, for the outpatients. But then when you get sick, the intensivists need to understand how to extubate the child back to what they were using as outpatients. So you really need more than one doctor, I
guess the thought of not having the trach tube scares me, because I saw what she went through when she was really sick with the cough and the suctioning and the everything that they were doing to her in the hospital. I mean, it was miserable to watch. And now I feel like I can manage her at home.
Yeah. No, you're absolutely right. It is easier to manage respiratory infections when you have a trach tube. I'm not telling you that it isn't. It's brutal if you don't have a trach tube. For 2 weeks or more, you could be using the cough assist, watching the oximeter 24 hours a day. And, sometimes our patients are so exhausted by that that they come in and get intubated for as little as 24 hours. And so we'll intubate them for 24 hours so they can rest, and we ventilate them and use the cough assist through the tube. And then after 24 hours, we extubate them and they go back home.
I see.
But you're absolutely right. They can be managed much easier at home when they're sick. But the problem is they get sick more often, and 4 out of 5 people with trach tubes die because of the trach tubes. because of bleeding and bad bacterial colonization, pneumonias, hemorrhage, tracheoesophageal fistulas, tracheectasis, the tracheas break, and so on. You see? And frankly, the average life expectancy with the trach tube, once you get a trach tube and using a ventilator, people live an average of 7 years. Now, I have a patient who is 24-hour vent dependent through a trach tube from 2 months of age with SMA type 1, who died from a pneumothorax at the age of 23. Right. So even though the average survival is about 7 years, you can live more than 20 years on trach ventilation. I know that. Now, with the non-invasive management, almost none of our patients are dying. It's absolutely amazing. So you need to understand that 20 years ago, I told the parents of 2 of these kids that they'd be dead within a year if they didn't get trached. And they forced me to use the non-invasive ventilation that I was using on Duchenne and ALS patients on these babies. And I didn't think it would work because they have no bulbar muscles. They have no throat muscles at all. But all these kids are still alive today. It's amazing to me. I can understand why other doctors don't believe it, because it's actually amazing to me as well. Right. So it can be done. Is it easy? No. Now, for example, 2 of the brothers that I have were only hospitalized once in 35 years between them for pneumonias at the age of 8 and 12. And they were intubated about a week. We extubated them back to non-invasive ventilation, nasal ventilation, 24 hours a day. And they went back home. And the last one, when he was 12, that was about 7 years ago. So they haven't been hospitalized in 7 years, and even more. So, you know, after they're old enough to cooperate with the cough assist, after the age of 5, they rarely get hospitalized again. But during these colds, it's absolutely brutal. Believe me, I understand that. I don't say it's not. Is it doable? Yes, but it's tough.
Yeah. So that was the hard part, because she's rarely sick now, you know. Yeah. And if she is, we're able to manage it pretty well.
Right.
But
no, you're absolutely right.
Of course, do I always wish that she didn't have a trach? Yes. I mean, it would make things easier.
But tell me, when she got the trach, before she got the trach, how many hours a day was she using ventilatory assistance? BiPAP.
Oh, it was only at night when she went to sleep.
Okay. After she got the trach, did she wean back to nighttime vent use, or did she continue to use
No, unfortunately, no. And
yeah, but you see, that's my
The
point.
thing is, now I know. That's another thing I wanted to ask about weaning. I mean, she can come. It seems like, you know, when she wants to come off her vent, she can. When she wants to go in the pool, or she wants to go on the swing, or she wants to do things, she'll come off of it. And yeah, we have to suction her a little bit more, but she can do it.
But the amazing thing is that if we could get her trach out, she probably wouldn't need to use the vent during the daytime. And the trach makes you more dependent on the ventilator for a number of reasons. For one thing, it creates secretions that block the respiratory exchange membrane, and you need more ventilation to ventilate the lungs. So you have to breathe harder. And patients on trach ventilation, because they're bypassing the nose and the mouth, the brain doesn't realize it's getting enough air, and they always ask for more air, and the carbon dioxide goes down, and they're hyperventilated, so that if you discontinue them, they can't hyperventilate themselves because they're not strong enough to do that, see? So anyway, there are other reasons too. The trach actually makes you more dependent on the ventilator. There's really no good way to reverse that except to take the trach out. Now, I will tell you this. You should measure her vital capacity. You can do that through the trach tube.
Okay.
If the trach probably does not have a cuff, does it?
It does. And we put it up at night only.
Okay. You shouldn't do that. But anyway, that's okay. To measure the vital capacity, you inflate the cuff, you put the spirometer on it, and then you ask her to take a deep, deep breath and exhale it into the spirometer, and that's how you get the vital capacity. Now, if it's over about 100 or 150 milliliters, it would mean that without the trach, she wouldn't need a vent during the day. If it's less than 50, then she would definitely need the vent around the clock, you know, which is, you know. But I suspect she's well over 100 milliliters. You really shouldn't inflate the cuff during sleep. You should compensate the leak by increasing the volume on the ventilator.
She's on pressure support?
Well, when you say pressure support, do you know the settings on your machine?
I do.
What is it?
So she's on 21 as her, I guess the PEEP is 8, She's on a respiratory rate of 12. The pressure support, let me just look. Yeah, the pressure control is 21.
Okay.
The pressure support is 9.
Okay. There are a couple things that are not quite compatible from what you're saying. I mean, I don't know. She may be on what we call SIMV, synchronized intermittent mandatory ventilation, where she has pressure support for her breaths, and she gets a mandatory pressure otherwise. I don't know.
She gets 12 breaths no matter what, and then if she wants to take extra ones,
right.
The support is a little bit less. I forget, 15 or something.
It's true that with the trach tube, a little bit of PEEP is not inappropriate because you lose what we call, it's a little bit technical, we lose auto PEEP.
Right, because there's nothing to hold it in.
No, but the PEEP of 8 is much too much. The PEEP shouldn't be more than 4. Yeah, it shouldn't be more than 4 because it makes it's more uncomfortable and the other thing is, if you did deflate the cuff, you could not maintain the PEEP. They would be leaking, and the machine would auto-cycle. It's complicated. In general, like I said, the patients don't need any PEEP. If you have a trach tube, a little bit of PEEP is not inappropriate. But the problem is that it's hard to deflate the cuff and ventilate the lungs if you give PEEP. And I'll tell you what the problem with the cuff is. I told you before that 4 to 5 people who are ventilated through trach tubes actually die because of the trach tube. But most of them, it's because of the cuff. It's the cuff that causes almost all of the damage to the trachea and the airways.
Okay.
The other thing about the cuff is that when you inflate the cuff, the secretions lie on top of the cuff and they gradually drip into the lungs. And as they lie on top of the cuff, this pathogenic bacteria that's on the foreign body of the tube itself become what we call purulent, very infectious, and they drip into the lung. If you deflate the cuff or remove the cuff and you compensate the leak, so in other words, if you're ventilated at a pressure of 20 and you deflate the cuff and the ventilator compensates the leak by maintaining a pressure of 20, then what that does is half the air comes up around the trach tube and it blows the garbage that's on top of the trach tube up and out. So it's much cleaner and healthier for the airways. Plus, she's able to talk.
Right, at night.
If the air is coming up through the vocal cords, she can speak. And if the other half will go into the lungs. So my point is that number one, the cuff should not be inflated. And if you can ventilate her without the cuff being inflated, then it should be removed. Now, the cuff damages the trachea so much, and it inflames it, that, well, usually if the cuff is deflated and you try to ventilate patients overnight, it hurts. But since her cuff is deflated during the daytime, it might not. So what I suggest you do is not inflate the cuff, but let the machine compensate the leak. Monitor
so we'd have to change the pressures at night then, right?
Well, no, not normally, because since it's set on a pressure, the machine will automatically try to compensate the leak.
Oh, right. Okay.
So it'll increase the volume until you get the same pressure.
Right.
If the pressure drops very low, then it's not able to compensate the leak, and then you haven't got a good machine, basically.
But you can make the flow higher, can't you?
Well, the flow doesn't matter. The flow is not the volume. What you mean is you want to make the volume higher. If it's volume set. See, what state?
No, it's not.
What state do you live in?
Rhode Island.
Well, you're not that far from New Jersey. You really should come. You really should come for an appointment, with your equipment, so we can sort of get straightened out.
Okay. Yeah, I don't want to monopolize them.
Rhode Island is so close, and you will learn so much, and we can make it probably more comfortable and effective for her.
Okay.
Let me give you the telephone number of our scheduler. Her name is Grace. It's 973-972-2809.
Okay.
Yeah, Rhode Island is so close. We get people from all over the place.
Oh, yeah, we've done the trip before.
Okay. Wait a minute.
Thank you.
Cindy, isn't it?
I'm sorry?
Are you Cindy?
I am.
Yeah, right. But I don't think, did I meet Ellery?
Oh, no, you haven't met us. No,
Okay.
we actually went to like a swallowing clinic in Jersey.
Oh, really?
For a bit.
Oh.
Yeah, where they do that vital stim.
Ah, yes. Well, our therapists do that too. You know, if her vital capacity is a couple of 100 milliliters, and she's able to breathe for periods of time during the day, and she has used BiPAP in the past, so she knows what it is to use nasal ventilation. My therapist, Lou Saporito, and I, we're awfully anxious to remove trach tubes. I have to tell you. I mean, we really haven't done it on 6-year-olds because the kids get
you're making me very nervous even talking about this.
Yes.
Yeah, but I am intrigued.
No, I don't blame you. Don't worry. We won't take it.
Okay.
But it's just that we're so tempted, you know, because we know that the kids don't need them. And that destruction that they cause with time, you know.
Right.
So, Dr. Bach, there's one more question I think you must have was about inhaled steroids.
Oh, yes, the inhaled steroids. Oh, boy, inhaled steroids in general are not a good idea, especially if you have a trach tube, because the bacteria are so pathogenic, and then if you give steroids, that depresses the immune system. Now, steroids are good for 1 week if you want to decrease airway secretions, and you know you have a viral infection. But steroids should not be taken for more than 1 week at a time by anybody, really. Unless you have some inflammatory disease and you have no choice, you've got to take them. Because the side effects of long-term steroid use are absolutely horrible. If you have a trach tube, and with all those bad bacteria there, to take steroids continuously, there's no indication for that. I can't imagine why anybody would even suggest that. Now, if for kids who don't have trach tubes, if you have an acute infection and it's viral, I think it's okay to take steroids for 1 week to try to decrease these secretions. But that's all. It shouldn't take it longer than that.
Hello, my name is Tracy. I have a question. I'm calling from Hawaii.
Oh, Hawaii. Boy, I'm going there in a couple of weeks.
Oh, God, I would love to meet you. I have a question. My daughter's 7. I have twin 7-year-olds with Nemelin myopathy, and my daughter is more severely affected with respiratory. She's not on a trach. However, we just received a trilogy last year, and it was amazing. She's so much more efficient with her breathing because of this machine compared to the BiPAP we had before. And we just recently received a cough assist, the new T70. And I have one question related to that, and I have another question related to a sleep study titration. My question with the new cough assist, it's able to do an auto cough track, I guess,
Excellent.
instead of a manually set pause. So do you suggest
Absolutely. It's great.
Okay.
The kids trigger it themselves. It gives them the cough when they need it and they feel it. Yeah, the auto track is terrific on the cough assist. But let me tell you, I'm sorry, go ahead.
No, go ahead, I'm listening.
I want to tell you something about the trilogy. From what you've told me with the titration studies, you are definitely using the trilogy on BiPAP settings, which is not ideal. But do you know what the IPAP and EPAP are?
I think she's 19/6.
Okay. Well, those are very good settings, but just decrease the EPAP to the minimum, to 4. But honestly, since she doesn't have a trach, she should be getting no EPAP. 19/0 would be far better than 19/6, because 19/6 is the equivalent of 13/0. And these so-called sleep studies with the polysomnograms are totally useless for this, because, like I said, no, the polysomnograms are a waste of time and money. You can, first of all, they almost never monitor the carbon dioxide during sleep. Ventilation is a function. I mean, carbon dioxide goes up if you're underventilated, and it goes down if you're overventilated. So to do a so-called polysomnogram without monitoring CO2 for somebody with weak muscles is completely inappropriate. The only thing that's useful on the polysomnogram is the oxygen saturation. But they've got these little machines that measure oxygen saturation and CO2 in one tiny little box. We measure them on the patients at home. They don't come into a hospital to get electrodes on their heads as though they had narcolepsy or something. And the other thing that's inappropriate is the titration. The reason the titration is inappropriate is because when you have sleep-disordered breathing, like obstructive apneas, you want to titrate away the obstructive apneas so that you can use your muscles and ventilate your lungs correctly. But when the muscles are weak, the goal is not to titrate away obstructive apneas. It's to rest the muscles during sleep so that you're stronger during the day. The reason that your daughter is better using the Trilogy on these BiPAP settings is not because, previously she was using BiPAP 2, but she was probably using 8 and 4. Now you're using settings that gives her a 13 centimeter of water boost to her inspiratory muscles. Now 13 is much better than 6 or 4, but it would be better if it were 18. Because then she would get better rest, better chest expansion, and have better lung growth.
Okay.
So 19 and 0 would be better.
Okay.
Now, I have to tell you this. The Trilogy is a very versatile machine. It's being used on your daughter to deliver BiPAP, but with a different hose, what we call an active circuit. It can also be used to deliver pressure ventilation with no EPAP. Or it can be used to deliver volume ventilation with no EPAP. It really should be used on a pressure mode, on assist control, with a pressure of about 18, with no PEEP, no EPAP, and a backup rate. That's the way it should be used. But to do that, therapists would have to, and the doctors would need to understand it, and they don't. I'll tell you the most common mistake. When we switch patients to that, they don't cover the holes in the nasal mask. See, the nasal mask that she's using has holes in it so that when she exhales, the air can go out of the holes when she's getting BiPAP, okay?
Right.
If you switch that to where she gets only the inspiratory pressure and not the expiratory pressure, and you use it on pressure cycling on the Trilogy, on what we call assist control, then you have to plug those holes, or you have to get an interface that doesn't have the holes. Now, they do exist, but the doctors and therapists don't understand them and don't know about them. They just don't think in those terms, see? So that's a problem. So that means that's why we educate the parents, and we say, get the right circuit, what we call an active circuit, and cover the nasal interface, and then it's much more comfortable and much more effective. So 18 or 19 and 6 is okay, but 19 and 0 would be far better. And if nothing else, if you leave her on the BiPAP setting, at least you can decrease the EPAP to the minimum, which is probably 4 or maybe 3.
Okay.
So you really should do that on your own. You should do that on your own, frankly.
Okay.
You can't turn the EPAP off. On BiPAP settings, you cannot turn the EPAP off.
Okay, so massive, and they haven't been removed yet, so I don't know. They haven't looked at them, and I'm working on that next.
I don't buy that. See, if you're giving a pressure of 19, the obstruction is really when you exhale. They're giving, the EPAP is creating pressure to stop you from exhaling. It's not helping you inhale. If you're giving a pressure of 19 centimeters of water, do you think that air is not going to come out of the lungs? You have to give EPAP to keep the airway open? It's got nothing to do with the tonsils. It just doesn't make any sense. The reason that the doctors don't understand this is because they're used to treating old people who snore.
Mm-hmm.
That's the only reason, believe me. Polysomnograms are completely useless. I've managed several thousand people this way, including hundreds who are continuously ventilator users. We've never done polysomnograms. We've never needed them. If I've been able to do that, and I have hundreds of people who don't have trachs and are 24-hour vent users, why would anybody need a polysomnogram? They just don't understand it. It's a waste of money and a waste of time. And then they put people on uncomfortable BiPAP. That's the way it is.
Yeah.
So are you saying for kids that don't have trachs or anything, that you don't believe in exhale pressures? Or
That's right. It's not a question of belief. They not only don't need them, they're counterproductive. And they're uncomfortable.
Because I would imagine most of the kids are on BiPAP in our group. Is that right?
Sure, they get used to it.
Okay.
And they've gotten used to it. But think about it yourself. The inspiratory pressure is fine. Do you want to stick your head out of the window of your car going 40 miles an hour to exhale? Do you?
That's CPAP, though, isn't it? I thought that I guess it is
you're
it's a lower pressure, right?
These kids only need the pressure when they inhale. They need the first half of the CPAP.
Okay.
They don't need the pressure stopping them from exhale. Just think about it.
I don't know. I guess I always thought that
they're treating
I thought
people
that the lung needed it.
You know, they're not treating weak muscles.
Okay.
You know, that's what it is.
I met the Respironics representative lately, and he encouraged me on the next visit to have my daughter titrated with AVAP on the Trilogy because I guess the sleep technicians aren't using the machine to its fullest capacity, and it's able to do so much more. And he suggested titrating with AVAP.
First of all, there should be no titration. The goal should be to rest the muscles overnight. To do that, you need a pressure of about 18 centimeters of water when you inhale and 0 pressure when you exhale. So the goal of titrating, in my opinion, is 100% wrong. Once you titrate somebody who's getting weaker, you got to titrate them again sufficiently so that they're stronger during the day. Therapist or the representative there, I'll tell you what AVAPS does. AVAPS guarantees a certain volume so that as the pressure of the machine, as there's leak, the machine more precisely compensates for the leak. AVAPS is BiPAP, and so I don't use it. But now, are there exceptions? Yes. When there's spasticity in the throat, like in Lou Gehrig's disease, and patients cannot air stack, they cannot take a volume of air and hold it and get another volume and hold it, so that they don't benefit from volume cycling, then I use pressure. And I'll actually use BiPAP for ALS patients because they do have spasticity in their throats. But I don't use BiPAP or EPAP for people with weak, or simply have weak muscles. It's just not the best thing for them.
Okay.
You can get away with it, but you know. But it's very good that the inspiratory setting is 19, though. Because 19 minus 6 is 13. And that's a lot better than 4 to 6 that most of these sleep doctors use, you know.
I see. Thank you.
Dr. Locker, in case you have to leave soon, I think there's one more issue that I think you should address, which in my experience comes up when the fear of using the cough assist too much, particularly by doctors and ICU doctors, and too often, and the fear that it might collapse the lung because of the negative pressure, and the fear of using it too high pressures through the endotracheal tube. Can you comment on that?
Well, I did a little bit, but there's nothing that can be done to convince doctors who have grown up learning to fear barotrauma in their severe lung disease patients. They simply extrapolate that to people with normal lungs. Now, my patients have been, first of all, my patients have been air stacking in many cases for over 50 years to pressures of 90 centimeters of water. So understand, I didn't tell you what I meant by air stacking, but when you have good throat muscles and you get a volume of air, say a liter of air, you hold that liter and then the machine gives you another liter and then another liter, and now you've got 4 liters of air in your lung. The pressure in your lung at that point is about 80 centimeters of water. You do that 15 times, 3 times a day for 50 years, and nobody has ever had any barotrauma or pneumothorax. The cough assist doesn't even come close to these pressures. When my patients do this, they maintain normal lung compliance. In other words, their lungs stay elastic and healthy. If they don't fully expand their lungs using pressures of 80 centimeters of water or so, the lungs shrink. They become small and tight. So the cough assist pressures don't even approach the pressures that my patients use 3 times a day And in many cases, they've been doing it for over 50 years. But if you I've never used the cough assisted under 40 centimeters of water pressure. And like I told you, even that was a mistake. It should be used at 50 to 60 centimeters of water pressure. And I'm writing that now, and I'm doing a study for Philips Respironics. That will be documented. And but even after that's written, that's the unfortunate truth. Yeah.
Are you saying, so for our kids, minimal 3 times a day with the cough assist just to inflate their lungs to keep them elastic?
Right, just the positive pressure, yes. Just the positive pressure. About 15 times, 3 times a day. And again, through a trach tube, you're going to have to use it at 60 to 70 centimeters of water. But now, look, understand that you use the cough assist until the lungs are fully expanded clinically. So when the chest stops rising, the lungs are 90% full. Then if you have to cough, you go to the negative pressure. And when you see that the lungs stop emptying, you go back to the positive pressure. The same is true if you use it 3 times a day just for lung expansion. If you put the positive pressure on 70, the lungs are going to fully expand sooner than if you put it on 60 or 50. But the point is that you watch the child's chest, and when the lungs stop expanding, that's enough. If you put it on 40, it's going to continue to expand for 10 seconds. And then the child's going to get short of breath because he's not able to breathe during that time. So the purpose of the flow and the pressure, really, the higher the pressure, the sooner you can inflate the lungs. And you want to do it fairly quickly so that the child doesn't become short of breath. Okay? That's the main idea.
I wouldn't want, and we put the cuff up during the cough assist, so I would imagine it'd be a little different, cuff down.
You're right. The cuff should be inflated when you use the cough assist.
Okay.
You're right. The only time that a cuff is useful, should be used and inflated, is to use the cough assist. But I would normally remove the cuff and use the ventilation overnight and let the machine compensate the leak with setting the pressure.
Okay.
It's better to remove the cuff and protect the trachea from the damage from the cuff than it is to leave the cuff just to use the cough assist.
Okay.
There's advantages and disadvantages both ways, but my advice would be to ventilate with the cuff deflated, and once you do that, the next trach tube change, put in with no cuff. And even though the cough assist will be less effective, the damage to the airway from the trach tube overrides that.
Really? Okay.
Yeah. Oh, the cuff causes most of the damage.
So when they go to do a bronch, they're going to take a look at her airway in June. What are they going to see? Are they going to see damage? Wouldn't they report that to me?
First of all, why would they do a bronch?
They do a bronch every year to look at her airway.
There's absolutely no reason for it. It's just, again, a totally useless invasive intervention. There's no reason for it. When you say a bronchoscopy to look deep in the lungs, that's different from a laryngoscopy. If they're just going to look at the trachea, that's fine. See, 17 to 65% of people with trach tubes develop tracheal stenosis. And when that happens, you can't remove the trach anymore, and the trachea needs to be sounded. It needs to be physically expanded, and it can rupture, and it can rupture. But also, the cuff causes tracheectasis, which is a bulging of the trachea itself. Now, you don't need to do a bronchoscopy for either of those. All you need is an X-ray. There's literally no reason that I can think of. In fact, I'm positive there's no reason to do a routine bronchoscopy. It's uncomfortable and unnecessary. It's just, it's just totally unnecessary.
So by doing an X-ray, they'd be able to tell if she needed like a larger trach. Like, isn't that part of the reason they do it too, just to check size and stuff like that?
No, you don't need to do a bronch to do that. First of all, if her SATs and her CO2 are normal, she doesn't need a bigger tube.
Yeah, they are.
Well, then she doesn't need a bigger tube. And as she grows, what size tube does she have? A size 4?
It's 4.5, actually.
Well, that's actually big. You can get by with that as an adult. you don't even have to think about increasing the tube anytime soon.
Okay.
You know, in fact, again, when she's 12 or so, you may consider removing the tube. Can she speak?
Yes.
Well, she definitely should have the tube out. It's horrible, horrible. if she has the throat muscles to be able to speak and articulate speech, and she has a trach tube, it's a disgrace. It's really terrible. My therapist and I, it drives us crazy to see things like that.
Yep.
Yeah. Because she may really be able to breathe pretty much all day without the vent, without the tube, you know?
So wouldn't the first step...
Get her vital capacity. It would be very important to see how much she has at baseline. Yeah, you were saying.
No, I was going to say, I mean, wouldn't the first step be to just see if she can come off her vent all day with the trach?
No, because the trach makes you more dependent on the vent. Once the trach comes out, the vital capacity goes up automatically by 20-30%. As the vital capacity goes up, you're able to breathe better. It's very difficult, if not impossible, very often to wean people once they get trach. But once the trach comes out, they all wean. Provided that the vital capacity goes to at least 250 for adults. For children, about 100.
That's a test that the pulmonologist can do.
Yeah, but they won't do it.
Well, if I ask them to.
They won't even know how. They probably won't know how. You know why? Because what they always order are pulmonary function studies. You go to a laboratory that's designed for people with lung and airways diseases, and they measure a lot of things. Plethysmography, sometimes they do arterial blood gases, they do sniff, they measure a lot of things, and they measure the forced vital capacity, which is designed to measure flows in people with airways diseases. Now, the forced vital capacity is the same as the vital capacity for people with weak muscles, and that's fine. But they also should be measuring the vital capacity in different positions, like sitting and lying down, but they don't know enough to do that. Also, the CO2 and the saturation are very important. So if they can't send the patient to the pulmonary functions laboratory, they don't know how to measure a vital capacity. All you have to do is get a manual spirometer and attach it to the trach tube. Inflate the cuff and have the child take as deep a breath as possible and exhale. The air goes into the spirometer and you have the vital capacity. All the things that are necessary to measure, the carbon dioxide, the oxygen saturation, the spirometry, and the cough flows, you can measure in a couple of minutes in an outpatient visit. Pulmonary functions laboratories are almost completely useless for people with muscle weakness.
Okay.
You know?
Well, once a year they do like an overnight, they just monitor her.
The polysomnography,
the blood
right?
gas. They just no probes or anything, just that they do a blood gas and then they...
So they stick her arm to do a blood gas?
They do. They stick her foot,
So you torture her for that. We never do that.
Yeah. Okay.
And you know why we never do that? Because 30% of people hyperventilate from the pain of being stuck, of having their arteries stuck. So the carbon dioxide is not accurate. What we do is we measure the end-tidal carbon dioxide, or you can measure transcutaneous carbon dioxide. It's completely...
correlate it.
Excuse me?
And then they correlate it.
Yeah, but you don't need to correlate it. We already know that you see, you need to correlate it for people with lung disease who have diminished diffusion. So if you have COPD, you need to correlate the arterial CO2 to end-tidal CO2. You don't need to do that when people have healthy lungs and normal diffusion. Okay. You completely don't need to do an arterial blood gas. The end-tidal CO2 or transcutaneous CO2 is more accurate than the arterial gas, and it's completely painless.
Dr. Bach?
Uh-huh.
I have a question that's a little bit different from what you've been talking about, but thank you so much for all of that great information. My question is about a treatment that a lot of parents use with their children, and I'm wondering, can nebulized albuterol, saline, or hypertonic saline be helpful? maybe at least during an acute illness?
During an acute illness, it does seem to help some people. Routinely, it should not be used because it sensitizes the heart, the myocardium, to sympathetic stimulation. And, sometimes patients develop cardiomyopathies, some heart muscle weakness, and you don't want to use these medications routinely. However, when people are sick, I ask the patients, and very often they say that they feel that it does help them clear airway secretions. Now, in theory, should it? No. There's no theoretical reason why it should. Because albuterol, for example, is a bronchodilator, and it's theoretically of use for people with airway constriction that happens when you have asthma, or what we call reversible bronchospasm. But there's no reason why people with myopathy would have that unless you have asthma also, you see. But the patients do feel, and we have no evidence that this is the case, but if the patients feel that it helps them when they're sick, I think it's fine. But it should not be used routinely, no.
Okay, thank you.
Yeah.
And then I have another question, too. There are some adults who currently use trachs that say they prefer using a trach. So does it kind of come down to just personal preference?
That's a very good question, and I'll tell you. When I've heard that in the past, it's always because before they got the trach, they were either not ventilated at all and very symptomatic, and even worse, every time they would get sick, it would be a nightmare. They would have pneumonia, they'd get intubated, they'd struggle to get back. It was always because their doctors didn't know how to take care of them by using non-invasive ventilation correctly and using the cough assist correctly. In fact, everybody who has a trach, if you ask them, well, did you ever use the cough assist before you got trached? I can tell you with close to 100% certainty the answer will be no. If you ask them, did you ever use non-invasive ventilation before they got trached? I can tell you with 100% certainty, if they ever did, it was BiPAP. In other words, it was wrong. With 100% certainty, I'm telling you, if you give me an exception, somebody who says, well, I'm happy with the trach, but I was using the cough assist before, and I was using non-invasive ventilation, but I'm much happier this way, I frankly wouldn't believe it. I would find it it would be impossible to believe. The only people who say they're happier with a trach after they get them are people who are completely mismanaged and left to go into respiratory failure, and then they rationalize to themselves that, well, now I've got the trach, I'm better off with it, I'm happy. That's really the way. Tell me, would you want a trach and you don't need it? Of course not. I don't want a trach. No, I mean, if you can be managed without a trach, anybody would want to, unless it's more difficult. If you're managed correctly with non-invasive ventilation and the cough assist, it's not more difficult, except for kids when they get respiratory infections. And then you have a trade-off. But the problem is the trach makes you more dependent on the ventilator, it prevents the development of speech, and it makes swallowing more difficult. So is it really worth it? Now, for kids, in general, it's not worth it. For adults, it's never worth it. Never. Anybody who's an adult using a trach ventilation and can speak and says they're happy with the trach, it's because they were totally mismanaged. Mm-hmm. Now, if they can't speak and they can't swallow and they have bulbar ALS, then they do need a trach to survive because they aspirate so much saliva that their saturation stays less than 95%. You see? Mm-hmm. But, in fact, that's the only indication for a trach tube. If you aspirate so much that your oxygen saturation stays below 95%, I'll be the first person to tell you need a trach tube. But that only happens in bulbar ALS, Lou Gehrig's disease. I've never seen it in Nemelin myopathy. I've never seen it in SMA type 1 or 2 or 3. I've never seen it in Duchenne muscular dystrophy. I've never seen it in I've never seen it in any other condition, only in Lou Gehrig's disease. And I tell them that when they need a trach, I tell them.
So, Dr. Bach, sorry, it's Cindy again.
Yes,
so
Cindy.
It sounds to me like with our kids, like if I had known that we should definitely start them on that cough assist as early as possible?
Well,
I don't know
again,
how young a child can be and use it. I mean, I know you were talking.
No, we use it on infants. We use it on infants. We time it to the kid's breathing, even on kids 3, 4, 5 months old. But
so
remember
knowing that the kids have weak muscles, it just sounds like something that they should use, that everybody should use.
Well, hang on. Let me explain something a little bit further, okay? I think I told you before, I did tell you before, that kids with SMA type 1, despite what we do, get hospitalized almost twice a year until they're 3, then once every 3 years until they're 5, and then almost never afterwards because they're able to cooperate with the cough assist.
Okay.
Now, what does that tell me? That tells me that the cough assist is not all that effective when they're really small, because they're really, even though we're trying to time it to their breathing, it doesn't work every time to prevent pneumonia by any means. So, now I'll tell you what we discovered. We discovered that by putting people on pressure ventilation at pressures of 18 to 20 centimeters of water, when they're diagnosed and when we see paradoxical breathing, in other words, when the belly goes out, the chest sinks in. When we see that, if we put the child on ventilation, even if their CO2 is normal, their chests develop normally. If we don't put the child on ventilation, nighttime ventilation, they die. They die because their lungs don't grow. And they have what we call a pectus excavatum. Their lungs, their chest walls are very, very thin, what we call funnel-shaped. And they don't survive. But their lungs don't grow. So there is no doubt, no question, that in small children who have paradoxical breathing, essentially everybody with SMA type 1, half the kids with SMA type 2, and most of the kids with Nemelin myopathy, all of them who have paradoxical breathing, they need to use nighttime ventilation. Now, can you use BiPAP? Sure, but it's not ideal and it's not so comfortable. But the point is the inspiratory pressure needs to be 18 to 20. If you use it at 18 to 20 and the child is in synchrony with the machine during sleep, it's amazing how normally the lungs grow. If you ever see me lecture, I will show you amazing kids with Wernicke-Hoffmann's disease, SMA type 1, now 20 years old, with chests the size of normal. When you look at them, they look like they have normal-sized chests. But if they hadn't been using ventilation as babies, not only would they not have survived, their lungs wouldn't have grown at all. So it's not the cough assist that promotes the normal lung growth in infants. It's not the cough assist, or the cough assist is not necessary to promote good lung growth in infants. But once the kids are old enough to cooperate with the cough assist, then even if they don't need nighttime ventilation, if their vital capacities are less than 80% of normal, they need the lung expansion for the lungs to grow properly. I hope you understand what I just said.
Yep.
The goal is to expand the lungs maximally. I don't care if you use BiPAP, the cough assist, pressure ventilation.
Bag.
An ambu bag is a volume ventilator. It's a volume ventilator. You inflate the lungs until you see the chest fully expanded and the belly, and then you let the air out. That's a cheap way to do it. We have patients who block the exhalation valve, and they use the ambu bag to inflate the lungs. It's a lot cheaper than a cough assist.
Right.
And it's just as effective.
Okay,
so the cough assist can be used for the insufflation, for lung inflation, to promote normal growth, but also for coughing. And so to just arbitrarily use it 3 times a day at pressures of 20 or 30 is not accomplishing anything. It's like using the vest. It's would be useless at that point. So it's important to understand the physiology and what you're trying to accomplish. The goal is not to titrate away apneas and hypopneas. The goal is to rest the muscles during sleep so that you're stronger during the day. To do that, you need pressures of 18 to 20.